Hello, welcome, and thank you everyone for joining the Heart and Stroke Foundation's webinar, Post-Stroke Fatigue, Navigating Recovery and Everyday Life. My name is Rebecca Lund. I work at Heart and Stroke as the Manager Stroke, and I am so grateful to be moderating this webinar today. When you join today's webinar, your computer audio will be used and your microphone and camera will remain off. If you prefer to listen with your phone, you can select call me or phone call and follow the prompts for more options. Questions are welcomed throughout today's webinar via the Q&A panel. We'll address as many as possible during the Q&A session at the end, but please note that we are not able to answer raised hands. Lastly, today's webinar will be recorded and made available in a few days on the Heart and Stroke YouTube channel and the Stroke Best Practice website. Today, we would also like to begin by acknowledging the Indigenous peoples of all the lands that we're on today. While we meet today on a virtual platform, we would like to take a moment to acknowledge the importance of the land which we each call home. From coast to coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call these lands home. We do this to reaffirm our commitment and our responsibility in improving relationships between nations and to improving our own understanding of local Indigenous peoples and their cultures. We're gathered today because of a shared commitment to equity, including health equity and reconciliation, and we encourage everyone to reflect on what that means for you in your work and in your everyday life. So to get us started, we'll quickly review the objectives of today's presentation. The first is to describe what post-stroke fatigue is. The next is to recognize signs and impacts of post-stroke fatigue on daily life, recovery, participation, mental health, work, and relationships. The next is to identify practical strategies for managing post-stroke fatigue, and throughout the presentation to really reflect on the personal experiences of individuals living with stroke and post-stroke fatigue. I have the absolute honor to welcome our presenters today. First up, we have Dr. Mark Boulos. Dr. Mark Boulos is a stroke and sleep neurologist, associate professor, and a senior scientist in the Division of Neurology at the University of Toronto and Sunnybrook Health Sciences Centre. Dr. Boulos serves as the Regional Medical Director for the North and East GTA Stroke Program and as the medical lead for the Sunnybrook Sleep Laboratory. Dr. Boulos oversees an active research program that investigates the association of sleep disorders with TIA and stroke, and he has published more than 110 peer-reviewed journal articles, as well as many book chapters, abstracts, and poster presentations. In 2025, Dr. Boulos was awarded by the American Academy of Neurology the Sleep Science Award in recognition of outstanding achievements in sleep and stroke research. Next up, we have Heather Quiley-Goranson. Heather is a professional engineer and geoscientist who began her career over 40 years ago in the oil and gas industry, holding various challenging technical and leadership positions with a senior oil and gas company. She used this diverse expertise to create and lead the consulting firm Cavalli Consulting Limited, recently rebranded from Mara Development Corp, to guide corporations as they change their business processes to optimize operational and financial performance. Cavalli has a global client base which began in oil and gas and subsequently moved into mining, power generation, water management, and agriculture. During the pandemic, they used the considerable data management and analytics experience and developed a hosted environment serving agriculture, government fleets, and communities. Heather is the honorary consul of Norway for Saskatchewan. Since recovering from a hemorrhagic stroke in 2022, Heather has been involved with the various groups to increase awareness. And our third presenter is Aisha Khan. Aisha holds a bachelor's degree in occupational therapy from McGill University and a master's degree in applied rehabilitation from the University of Sherbrooke in Quebec. She spent most of her clinical career in stroke rehabilitation, leading and participating in quality improvement and knowledge translation projects, including national initiatives related to the Canadian Stroke Best Practice recommendations. Since 2019, she has served as a senior advisor for professional practice within the Rehabilitation and Multidisciplinary Services Directorate at Santé Quebec West Central Montreal Health and Social Services University Network. Disclosures of all presenters are listed on this slide, and we have a great session ahead. So let's get started. Mark will lead us through the first part of today's discussion. So Mark, over to you.
Wonderful. Thank you very much, Rebecca, for the very kind introduction. And also just want to thank the organizers for very kindly inviting me to speak on a topic that I'm very passionate about. Um, so, uh, so I just want to emphasize that post-stroke fatigue is very common yet unexpected by both patients their families, and healthcare professionals. It's a really disabling condition, and many people with stroke will tell you this. Yet it remains poorly understood, and that's why it's so important that we do webinars like this. I really highly commend the Heart and Stroke for putting on this webinar, bringing attention to an extremely important area. And we can be optimistic that there are management strategies that exist, even though it is disabling. There are management strategies that people can really benefit from. So it occurs in a large number of patients, about 30 to 70% of patients with stroke. And as I mentioned before, it is highly disabling. It can really occur anytime after stroke. Sometimes it's after the person leaves the hospital and they realize they're trying to get back into things to try to try to get back into daily life. But it can also relapse at other times. I'll give you some examples about that. It increases the risk of mortality, unfortunately, and that may be through an increased rate of diabetes, myocardial infarction, as well as psychosocial factors. Um, Individuals with post-stroke fatigue, particularly prominent fatigue, are more likely to admit it to institutional settings and be dependent on others for ADLs, such as like the activities of daily living. It can also decrease an individual's social participation and ability to return to work. And I've seen a lot of highly qualified professionals have a hard time returning to work because of the fatigue, unfortunately, they've encountered after their stroke. Finally, it's also closely linked with depression. So qualitative studies show that fatigue is often unexpected. The symptoms can vary, and the individual experience of fatigue is complex, influenced by multifactorial and psychosocial factors. It's often not discussed by healthcare professionals, not discussed during recovery. And again, as I mentioned a few times now, it's unexpected. So it comes out of a surprise. People feel sort of unable or unequipped to deal with this really important comorbidities. Families and support networks are also sometimes thrown off as well. So defining fatigue is a little bit tough, but the latest definition here defines it as a feeling of exhaustion, weariness, or lack of energy that can be overwhelming. And it can involve physical, emotional, cognitive, and perceptual contributors. It's not really by rest, and it affects a person's daily life. So very disabling, unfortunately. And this slide and these comments are courtesy of Dr. Jing Shi, with whom I did a symposium a few months ago at the Canadian Stroke Consortium. Um, we note that this post-stroke fatigue, what are the challenges with it? Well, it's complex. There isn't a single explanation. The definitions are inconsistent, and our measurements also are inconsistent. There may be different subtypes that we're working to better understand and need to be better understood. There can also be important confounding comorbidities, such as the associations with other sleep disorders, depression, mood, medications, and other things. The research to date has been quite limited often by small sample sizes, inconsistent metrics, and variable timing post-stroke. So some individuals can get the post-stroke fatigue, as I mentioned, immediately after, but others will have relapses throughout. The mechanisms for post-stroke fatigue can also vary quite a bit and are unclear and poorly understood. So overall, post-stroke fatigue is not really well understood. There is a lot of thinking, and probably the leading thoughts in the literature right now is that there's this post-stroke neuroinflammation that may occur. And that the stroke-induced inflammation, we know that in the area of the stroke core and the penumbra, there are significant physiological changes in that brain region. And that can modulate brain energy metabolism, particularly at the level of the mitochondria. So stroke itself can cause then this neuroinflammatory states. There can also be neurotransmitter dysregulation. We know that there's a close association with depression. And so both the serotonergic and dopaminergic systems have been implicated. Medications also such as modafinil have been used to treat post-stroke fatigue. That suggests that there may be a role of dopamine playing in the system. Finally, there can also be a role for immune dysregulation. And as you know, when you come down with the flu or COVID or any of these nasty colds, your immune system gets dysregulated. And if one's had the experience of post-stroke fatigue, there can be similarity between the two, where there's this state of being really exhausted, not able to really replenish energy with rest or sleep. So there may be, again, immune dysregulation, but again, the mechanisms are not really well understood at this point. There are some possible contributors, I would say, sort of risk factors for post-stroke fatigue. These are not well established, but there is some literature suggesting that women and those with diabetes have higher rates of post-stroke fatigue, also older individuals as well. If one had fatigue and depression before the stroke, then that can also increase the risk of post-stroke fatigue. Um, and then a lot of studies, if you look at studies such as looking at brain location, stroke type, or like the portion of the brain that was affected by the stroke, and hemorrhagic versus ischemic stroke, a lot of these papers and a lot of this prior literature doesn't really suggest any strong association between stroke location or type. But there is some emerging work that suggests that maybe more severe in ischemic stroke compared to hemorrhagic stroke. Anatomical imaging studies, which is with CT and MRI, do show some links, some emerging evidence with structures such as the basal ganglia, internal capsule, thalamus, and the brainstem. And an fMRI study, which is a functional MRI, showed that the basal ganglia may be linked with greater cognitive fatigue. So when someone comes to us saying, "Oh, I feel fatigued," we should be careful as healthcare professionals as to what do they mean by fatigue. And this is another slide from my colleague, Dr. Chi. But post-stroke fatigue is not mere tiredness. It's profound exhaustion, not really by rest. And there can be specific natures of it. So there can be different characteristics that some patients will come and say they have this heaviness. Their arms and their legs feel heavy. Motor related, it's really, they feel like they're drained. They can't lift their arms. It's hard to go up the stairs because their legs are so exhausted being dragged down. The brain can feel so effortful, just the brain fog. And there can also be different patterns when it starts, the severity, the duration, how does the environment impact them, and what does the fatigue interfere with cognition, speech, functional activities, and quality of life. And I'm going to elaborate this on my second part of my second time I have the pleasure of speaking later today. But it needs to be distinguished from other things like weakness, sleepiness, because sleepiness and fatigue are not the same thing. Also need to distinguish from psychiatric conditions like depression and also other related conditions like apathy and boredom. So as I was, preparing for this talk, I was like, wow, I wish I had a real life example from a patient. And of course, a patient emails me saying, "Dear Dr. Boulos, I've been experiencing a notable increase in fatigue over the last couple of weeks. And I want to check in with you about it." And he describes episodes of feeling unusually tired. It's become more consistent. Even when he gets a full night of rest, a full night of sleep, he finds himself needing to lie down again in the morning and sometimes later again in the afternoon. He tells me, "I slept for 7 hours overnight. I ate breakfast. And I went about my morning normally, but around 11, I felt tired enough that I laid down and fell asleep for about an hour. Later in the afternoon, I felt again unusual fatigued. This pattern isn't typical for me." Next slide. I should mention that I've had a number of stressors recently, including house-related matters, some personal things, financial, family dynamics, and he also participated in the Pride event as well in downtown Toronto, and he slept late. So as we can see here, this is a really rich description. Of course, this email is used with the permission of my patient, and I want to thank him for that. But you can see here there's a rich experience that patients can elaborate and describe to you. This slide is from my colleague, Dr. Patty Lindsay, again at the same symposium from the Canadian Stroke Consortium a few months ago. And she asked a number of different patients, describe to me what your fatigue is. And you see a really, really, really rich pattern here of different descriptions. Fear is pretty significant. I hit these wipeout days. They're misery for me, like they are low as the day can be. Looking back at what I used to be capable of and where I am now, I kind of grieve that person, and it's kind of a daily challenge for me. It's an onset fatigue, just complete turn of a switch. I have to stop. I can't actually continue it. I just have to stop. So really disabling for patients. and and um, and really something that we want to better understand. So again, patients can provide varied descriptions, and there seem like there could be multiple subtypes of post-stroke fatigue. I'm going to go into the next slide. It's my pleasure now to hand over the talk to Heather. Yeah, Heather, it's my pleasure to hand it over to Heather, who will share her experiences. Thank you so much, Heather, for being here and with sharing such an important part of your life. Thank you so much.
Thanks, Mark. I appreciate it. And thanks everyone for giving me the opportunity to discuss this because as we move to the next slide, I found I'm an engineer. I ran a company. I still do run the company, engineering company. And I was 4 days before my 3 days before my stroke, I was in New York getting dressed for my son's wedding and wearing ridiculously high heels and running around like crazy, like I normally did. And then suddenly, if we go into the next slide, I started coming around about 3 or 4 days later, and I'd had a massive hemorrhagic stroke. I couldn't move my arm or my leg on the right hand side. I was not speaking. Well, I thought I was speaking, but no one understood me, so that wasn't terribly helpful. But I was in that time period that friends and family came and rallied around me, and I then from that we moved to the next slide. I moved into a rehab facility, Wascana, and I think that was my lowest pitch. I was able to sit up. I was able to communicate at this point, but I was in a wheelchair, and if I wanted to go anywhere, someone had to push me. I wasn't able to handle that myself. I had a catheter. I needed support to get dressed. I needed support to get in and out of bed. I needed support with meals. So I was at absolutely my lowest ebb and started growing back from there. If we can slide to the next slide, I found that I had a major goal. So as I said, just 4 days before my son's wedding is when I had my stroke. So the wedding was postponed till June of the following year. And because of the great physio and doctors and people that I had with me and a lot of hard work, I was lucky enough to dance at my son's wedding. Most fun people that know me know this is really funny because I didn't dance before. So I apparently have a stroke and you start dancing. We can go on to the next slide. What I really wanted to talk about though is the fatigue. I want to talk about what it's like now as a person who's post-stroke person. I'm very fortunate. As you can see, I'm standing, I'm smiling, I'm able to move. But to do anything really changed how I work on a day-to-day basis. So when I want to go bowling, this was actually a fun bowling event for our company. And I was very excited that I got to go. But by the same token, here's the problem. First off, I got to get dressed. So when I used to get dressed, I would never think about it. But now I have to think, oh, I've got to do this. And then I'm going to have to move my right foot because sometimes my right foot works really well when I put my socks on. Sometimes it doesn't. So it takes a real long time just to get dressed. Next, I have to get to the vehicle. So I have to go get my walking stick out, walk over to the vehicle, get into the vehicle, get my leg moved around sufficiently so it's in the right spot, and then I can be ready to drive. The driving part, luckily, is very normal, and that part makes it really good for me. So actually, it's a place where you feel pretty good because you can drive like everybody else. But when I get to the place for the bowling, I have to get out of the vehicle. So I have to work my way backward, just like getting in. I'm now getting out, and it takes me a while. So pretty much everything I do takes extra time. And then walking into the building. Now, that would never seem to be a problem before. is suddenly I have to be a lot more careful about where I'm walking. Is there a problem? Is there anything that's slippery? Is there any uneven ground? And walking into the building, the walking was my favorite thing to do in the whole world. It still is, but it takes a lot longer now. So when you usually know you're just going to walk, you don't think about how you have to move your foot and how you're going to have to, how your knee bends and that sort of thing. For me, I have to think, oh, I should make sure that my heel goes down first, then my toe. Make sure you bend your knee. Make sure you don't straighten your knee too hard because it can really hurt yourself. And then take the next step. So each time you go through that, it wears you down. Then we're at the bowling alley. Well, the bowling alley is in the basement, so I have to walk downstairs. And again, it's the same process. Everything I think about, I have to figure out, can I walk downstairs? Can I walk down straight because it's on, has this handle or this guiding item for the stairs is on the left-hand side, I'm great. But if it's on the right-hand side, then I have to turn around backwards and walk downstairs. Then we have the whole challenge of getting shoes on, and these all have laces, so they have to be tied up. And then finally, it's my turn for bowling. So this sounds a little, what I would used to have thought of for going bowling was just, hey, sure, what time do I have to be there? And I would never have thought any more than that. Now I have to go through all this thinking process, and it really is very challenging, and it really does drive the fatigue. So what I would normally have wanted to do and done the bowling, for the record, I'm not a bowler, but it's just a fun thing we do once in a while. And the whole idea of this is figuring out, for anything I do, what am I going to do? What do I have to be prepared for? How do I look forward to make sure that everything is as safe as it possibly can be? Because if I fall, I have a chance I'll hurt something. And it's really easy to do that. And with the fatigue, what I find is that it's really a challenge as we work through the fatigue part. If we could kind of move to the next slide. It's not unfortunate. I say it can be tough sometimes. The real problem, I say, is the exhaustion, because just to get up, put my shoes on, and have breakfast, and maybe change the dishes in the dishwasher or have a quick meeting, I get so exhausted, and I really find it. I often have to take and plan things out so much longer. So what used to take me maybe 5 minutes will now take me 10 minutes. In a lot of cases, that's fine. But in a lot of cases, after that 5 minutes, I also then need time for rest. So one of the biggest things I've found is that I really have to give myself permission for the rest. I'm someone who is very active and used to being able to do more than my days were very full. Let me put it that way. And now I have to realize that I just can't do that, and I can still do a lot, and that's really great, but I have to think about it before I take anything on. So one thing I do want to think though is that it's exhausting, and I get really tired, and fatigue is draining. But the other thing I want to remember too is that I'm lucky, because I had the chance to live. The kind of stroke I have, most people die. And I've been very fortunate to get back and live and do things. And so we can go to the next slide. My focus is on how do I manage the fatigue and do the new things. So for instance, cooking, I love cooking. I can cook, but what used to take me, half an hour to get everything prepped for making a frittata, it now takes me about an hour by the time I chop everything up and do everything. Some things are very straightforward, like a talk or a presentation. That is sort of old school to me. So those ones aren't that much of a difference. I can do them, but I have to make sure that it's actually getting to and from that is more of a challenge than the actual talking part of it. But gardening, another thing I love, is something I have to be really cognizant that how I do things. And it's not that I can't, it's just I have to be a lot more careful about the timing and how I handle it. So I'm a person who is very happy to still be alive and be having the capabilities. But by having the people talking about fatigue and having people you can discuss that with, I find it really helpful talking with other stroke victims, or I don't like the word victim, stroke survivors, because it's really good to be able to have this conversation and say, this is a trick for me and how I manage it better, and giving yourself a little bit more time and fairness. And that's the end of my talk.
Thank you. Thanks so much, Heather, for sharing your experience. It was inspirational, enlightening, and I'm sure it resonates with a lot of people. So now I'm going to build a little bit on the themes that Heather touched on. We're going to be exploring how post-stroke fatigue can be identified and managed. So as we heard from our previous two presenters, post-stroke fatigue is very complex. It's multifactorial. It requires a collaborative approach, and a multidisciplinary approach, really with the person at the center, the person and their loved ones at the center. Next. So every person who has experienced a stroke should be screened for post-stroke fatigue. This can be done by a healthcare provider, it can be done by the person themselves or by a caregiver. There do exist some tools and questionnaires that could be auto-administered. And it should be done periodically, because post-stroke fatigue does evolve with time. So a perfect example is what Dr. Boulos gave about the email, right? So that person was experiencing something that is not like him. I believe those were his words, which means maybe before he did not suffer from post-stroke fatigue. And now it's something that's hit him, I don't know how many months after. Which is why it's highly recommended that a person be screened 3 months post-stroke, 6 months, 1 year, and then again after every year after that. So there are many elements that should be examined. I'm not going to name them all, but these should all be looked at when you're trying to detect post-stroke fatigue. It can be done by observation. So a healthcare professional can observe signs and symptoms during a session. It can be done through an interview or a discussion. So, you could just have that discussion, tell me how you're feeling today, and so on. Or it could be done by a validated screening tool. So here are just a list of tools that could be used. They've been used in literature for research purposes, but also clinically. And I'm going to go into, in the next slide, talk about quickly the fatigue severity scale. This is the most commonly used. It's a 9-item questionnaire that measures how fatigue impacts your daily life and activities. So it's really looking at the experience of the person. It's something that's easily available and has, as I mentioned, been used a lot in research and clinically. So before we get into the management, I want to, sometimes your healthcare team may not, for whatever reason, address or screen for post-stroke fatigue. So it's important that you can always express your symptoms, your feelings, and talk to your healthcare team about it. Like, again, I'm going to bring back the example that the wonderful email that Dr. Bula shared. That person decided to share it, to share their experience, and that could kind of trigger something in the healthcare professional to move on and maybe let me screen, maybe let me use this tool, maybe we'll look into some pharmacological or non-pharmacological strategies. So as we do talk about management, I just want to point out that there's no one-size-fits-all approach. Everybody's experience is different. So I'm going to go through this. I'm going to name we have about 10 strategies. Again, there are some things that are missing. There are some things that might work for some people and not for others. There's no one-size-fits-all. And also in terms of improvement, right? Post-stroke fatigue is something, as I mentioned, it can hit at different moments, but also recovery can be different from each person. So for some people, they can recover relatively quickly. For others, it really could last over a longer period of time. So we're hoping that, these strategies can help in just, you can pick and choose kind of like a toolbox of what works for you. So the first one is acceptance, right? So accept that what you're experiencing is real. It's common, you're not alone. So for some people, just putting that name, maybe I have post-stroke fatigue, putting that name to their symptoms can be incredibly validating. It can help make sense of their experience. So really that's step one. Step two, the next strategy is education, right? So feel free to discuss it with your team. If you have questions, talk to your healthcare providers. You can also attend webinars, just like you're doing today. or consult reliable resources. So there are a few that I listed there, and we can share them in the chat later on. They're just resources that are very easy to follow and understand and very easily available as well. So the third strategy is exercise, physical activity. Okay, so we all know, research has shown, and everybody knows how beneficial it can be, both for our physical self, our emotional well-being. It can help improve mood, sleep, and fatigue. So the key, though, it's really, there's kind of a nuance. We have to participate in activities at the same time. I'm tired. What do I do? So the key is to go slowly and listen to your body. So before you stroke, maybe you were able to walk for an hour each day. But now after 20 minutes, you need to take that break. Well, this isn't normal for me, right? But that's okay. I think you need to give yourself permission to kind of say, it's okay. I need to maybe take a break, or, maybe I do a little bit less today. The important part is really to stay active and try to be consistent as much as possible. So and it will build up. It could build up over time. And that's it. Engaging in those regular activities could help. And before we move to the next slide, I just want to have a little note for clinicians, right? So sometimes we forget, or it's really important for us to remember post-stroke fatigue in our sessions. And I love the example that Heather, you gave about bowling. And it's such an important point, because as a clinician, we'll look at our schedule and we'll see, okay, I have an opening at 9 a.m. Let me book so-and-so for 9 a.m. Let's consider maybe if this person is suffering or not suffering, but is experiencing post-stroke fatigue, well, just to get up and be there for that 9 a.m. appointment could be incredibly challenging, or could take a lot of time and be very draining. So if we could just keep in mind scheduling, for example, if somebody is, not having post-stroke fatigue and they are early birds, let's put them at 9 o'clock and let's put somebody else at 11 or later on in the afternoon. We can also make sure that we give breaks periodically and can vary the intensity as needed. So the next strategy, energy conservation. Okay, so words that OTs love. I'm going to use the model of the 4 Ps. It's very common. It's and a way to kind of look at energy conservation is to think of your energy as a cell phone battery. Okay, we all have times when our cell phone battery, even mine, I think I'm at 2% right now, but some activities, activities are kind of like apps sometimes. Some use more energy and drain our battery faster than others. Sometimes we need to charge more often, right? So just be aware of this and make sure that we have time to charge and to plan to better organize ourselves. So I'll talk first about P. The first P, sorry, is prioritize. Okay, so label your tasks. There might be some that are more urgent and important. There's some, put those at the top of your list, right? And this doesn't only mean something that you have to get done like a chore. It could be something like, again, dancing at your son's wedding. For that, that could have been a high priority for somebody like Heather. Maybe for somebody else, it's let me make sure that I visit my friends. That's a priority for me. So as long as you label them, figure out what could be urgent, make sure you could delegate many tasks to somebody else. Order those meds online, order those groceries, ask your friend to mow the lawn, right? So there are options. The next one is to plan and organize your activities in advance. So we can use a calendar or an agenda. And when I say in advance, it could be the day before, the week before, but just make sure it's in advance. That way you can make sure that you've engaged in tasks that require more energy, or take out more battery. You could do that at a time when you feel better, right? Or when your battery is at its highest. The next is really to pace yourself. Take rest when you need. You can do this anytime, right? So again, with the example of the cell phone, you don't need to wait till you're in that yellow zone or the red zone. You can also charge yourself up when you're green. So think prevention as well. If you know that you're going to be engaging in a very high energy activity later on, take a break maybe earlier on. Try to alternate between thinking and physical tasks. You could break up a task as well, right? So if you have to make dinner, how about you chop up the vegetables maybe in the morning, take a small break, and decide to cook the rest of your meal later on. And again, what I love, and sorry, Heather, I'm quoting you a lot because I really found your talk resonated a lot. I love how you said, give myself permission to rest, right? So it's really important for us all to do that. It's okay if today you need to rest. Give yourself permission and make sure that you take that rest. And the last one is position yourself properly. So minimize your distractions. If you have the radio on and it's not helping you, shut it off. You can remain seating for some activities. You're chopping up those vegetables. Why don't you do that in sitting? You can rearrange items so that things that you use most often, like the big pots, they're easier to get to. Keep your phone, all these objects that you use all the time, keep them close by. And also you can use adaptive aids. So I don't know if you know reachers and shoehorns and all these type of aids that exist out there. Feel free to use them to help facilitate your task. So the next strategy I'm going to touch quickly on is cognitive behavioral therapy. I'm sure you've heard about it. It's an approach that can help, really help. It's been shown in the literature to help as well with fatigue. It is done usually by a trained professional. So if it's something that interests you, feel free to talk to your clinician about it, and they can look into help you find a place where you can engage in that. The next strategy is mindfulness. I'm sure you've heard all about that. It's gained a lot of interest in the past few years. So it's been shown also in the literature to help reduce stress, improve mood, help with fatigue. There are many structured programs that exist out there. I think there's one that you should go once a week for 8 weeks. It's quite intense, but it's very structured. Then there are other ways that you can kind of just integrate some of these principles, deep breathing, meditation, yoga. You can integrate them into your daily routine. So again, I'm not an expert. It's something that has to be done with a healthcare professional who is trained. So again, if it's something that interests you, you can always reach out to your healthcare professional and talk to them about it. So next 7 is implement good sleep habits. Okay, so something that's good for everybody, not only people who are experiencing post-stroke fatigue. Again, this can vary, right? So somebody could just say, "Oh, I slept 9 hours and I'm still tired." But again, these are large guidelines that hopefully will help. So sleep for a sufficient amount of time, 7 to 9 hours. But again, make sure it's consistent. There might be a time when you slept 9 hours, but the day before you slept 5 or 6. Well, that could explain why maybe you're tired today, right? So try to make sure that you're consistent, that you have a regular sleep schedule, that you participate in regular physical activities, kind of like I mentioned before. That does help with sleep. You can consider a small nap in the afternoon. Okay, naps are not bad. Just try to limit it kind of to 20 to 30 minutes. Avoid screens before sleeping. This is something that is very, very difficult to do, but I try it out and you will notice a difference, or you should notice a difference, hopefully. Avoid caffeine after lunch. Okay, so if you need that fix for something warm, try to have non-caffeinated drink. Ensure you eat 2 hours or more before sleeping. Establish a relaxing nighttime routine. Okay, you could do deep breathing, music maybe. For some people, calming music helps. Relaxation exercises or whatnot. And enhance the environment, right? So you could use blackout curtains. You could make sure you have your fan if you need it. Have those earplugs if your partner is snoring next to you really loudly. So you could always find techniques to help with your sleep. Next is, yes, so now we've kind of identified many strategies, right? We went through our list. You have to choose now the ones, you know yourself the best. Choose the ones that are best for you. And more importantly, it's to communicate. Sometimes we know what we're feeling, but our partner or the people around us, they can't read our minds. So they don't know what you're feeling. Incredibly important to communicate with them. For example, let your partner know that, maybe after you go for a long outing, you're going to need that rest. If you work, right, go to work and maybe talk to your manager. There might be some adjustments that could be made to your schedule. Maybe during your appointments with the physio, with the OT, you could feel free to tell them, this activity is a little bit tough for me, or after this, I'd really like to take a break, because that communication is going to make it much, much easier for other people to understand what you're going through, and also it'll help you on a daily basis. Now, the last non-pharmacological strategy is kind of addressing caregivers here. Right. So we talk a lot about the person themselves. They have experienced, on many cases, a life-changing event. But a caregiver, even for you, right? Like in some cases, that event has impacted your life very much as well. So you play a very pivotal role. You're there. Your role is not, unacknowledged. Your understanding and patience, it can really make a big difference when it comes to post-stroke fatigue. And this has been shown in the literature. So some simple actions that can make the difference is, help all the strategies we talked about. Maybe you can help your loved one put them in place, right? You can be the one that says, you can encourage them. Maybe they don't want to take a break. You can encourage them to take a break. You can order the groceries or medications online. Also help them rearrange a few things. Okay, those pots and pans are too high, let's move them. But most important is kind of validating and believing them. And again, there's been some articles that have shown that the importance of a caregiver when it comes to post-stroke fatigue and the importance of that validation, it's huge. And the opposite as well, right? So if fatigue is downplayed or misunderstood, then the person who's experiencing it, they can have increased kind of stress and it can really impact their recovery. So your role, our role as healthcare professionals, your role as a caregiver, your role as well as a person who experienced post-stroke fatigue, it's we all play a role. And as a caregiver and a healthcare professional, it's not to make the fatigue go away. It's really to support one another and support your loved one, support your client as they learn kind of to live with this new reality. So that's the 9 non-pharmacological ones. I'm going to pass it to Dr. Boulos now to talk more about the medical strategies that could be in place.
Thank you, Aisha, for the wonderful talk, and thanks again, Heather, for sharing your insights. Really, both appreciate it so much. So there are some medical considerations. Aisha has provided some amazing strategies for managing post-stroke fatigue, but also there are some medical contributors that we would want, especially as healthcare professionals, to review. So, for example, just to keep in mind that not all fatigue is post-stroke fatigue. And fatigue also, there are associations of fatigue with other conditions. So one needs to rule out mood disorders such as depression, anxiety, stress. We know that comorbid mood disorders can play a significant role in mediating fatigue. Also, some medications and substance use can also cause significant post-stroke fatigue. So I do remember a patient who was referred to me after their hospital admission. They had been started on an anti-epileptic medication, and they told me, listen, Mark, or ever since I left the hospital, I've just been really, really, really tired, not feeling well, so on. So I'm like, okay, maybe it's post-stroke fatigue. But we also looked down their list and they were using, I believe it was carbamazepine. We stopped that and they actually improved their energy levels substantially. Blood pressure lowering medications as well, such as beta blockers, can also contribute towards significant fatigue and often started in the context of stroke and other cardiovascular disease. Antihistamine medications, pain or sleeping pills. I've just saw a patient today with extreme fatigue, very likely due to their sleeping medications being used. Sorry, their pain medications, their Lyrica and Mirapex being used for restless legs. Polypharmacy, and so on. Also, sometimes the use of variant substances such as cannabis sometimes contributes towards fatigue as well. We also want to rule out on a routine basis things like vitamin B12 or vitamin D deficiency, metabolic issues such as thyroid, liver, or kidney disease, as well as anemia and pain disorders. Also important to keep in mind are someone riding with a low blood pressure. Maybe they're over-medicated, their blood pressure is too low, or their cardiac function is poor. It may be worth a consideration in the correct context to get an echocardiogram. Dehydration can also play an important role. Finally, some infections like COVID. We know there's like long COVID, and sometimes that's associated with stroke as well, UTIs, pneumonia, and so on and so forth. Infections can play a role and be important to rule that out, especially if you have an acute onset of fatigue. Next slide, please. Then we also need to rule out sleep disorders. I'm going to just touch on the main 3 sleep disorders after stroke, just briefly here. The first one would be obstructive sleep apnea. Next slide. So obstructive sleep apnea is, and there are a few papers I've had the privilege of publishing with my amazing collaborators and amazing trainees. We do have one paper coming out recently, just was accepted like a couple of days ago as I was preparing my talk. 5 things to know about post-stroke fatigue. I hope it will provide a little bit of a summary. It's impressed with the CMAJ. We have some other papers that published in other journals to talk about different post-stroke sleep disorders if anybody's interested in reading that. Next slide. So obstructive sleep apnea is when there's this repetitive mechanical compromise and collapse of the upper airway, and it drops the oxygen. Throughout the blood and circulation. It causes fluctuations in intrathoracic pressure as well as intermittent awakenings from sleep. And the most common thing is you have like the typical stories. You have an overweight individual, usually a man, who snores, has witnessed apneas in sleep, but it's not always like that after stroke. And there are a lot of comorbidities with sleep apnea, such as obesity, hypertension, arrhythmias, and so on and so forth. It's very common after stroke, occurring around 70% of patients, depending on how you define it. Next slide. So here are some strategies. There are a lot of things you can do for sleep apnea. Please, if you or your partner think you have sleep apnea, very, very important to get checked out because it's a comorbid with a lot of important medical conditions. But things like weight loss, avoidance of hypnotics or alcohol, avoidance of sleep on their back, oropharyngeal exercises, a dental appliance, CPAP medications, and even up to surgery have been used in this condition. So just something really important to get checked out with because it can be quite harmful. Next slide. There's another condition that comes about a quarter of patients after stroke and about 5 to 10% of the general population, which is restless leg syndrome, also known as Willis-Eichbaum disease. And this is characterized by an urge to move the legs that worsens during rest or inactivity. It's relieved by movement and it's worse in the evening or nighttime compared to earlier in the day. And there are pharmacological strategies here such as iron replacement, the use of alpha 2 delta ligand medications such as gabapentin or pregabalin, or low dose opioids. Just for the clinicians in the audience, we no longer recommend the use of dopamine agonists in this condition. So that's just a brief overview of that condition. Our group was fortunate to publish recently in Nature Reviews Neurology a paper looking at the relationship between restless legs and stroke. So please feel free to check it out. Next slide, please. We also want to touch on insomnia. Insomnia basically is when somebody has persistent difficulty in initiating or maintaining sleep despite adequate opportunity and results in dissatisfaction with sleep and impaired daytime functioning. It's the most common sleep disorder in the general public, occurring in about a quarter of the population, depending how you define it, but it occurs in nearly half of stroke patients. Next slide. And there are also effective management strategies as well. There is something called cognitive behavioral therapy for insomnia, which targets the thoughts and actions that disrupt sleep. So, for example, you may restrict sleep restriction means limiting the time you spend in bed to match the actual sleep time. So, for example, if someone wants to be sleeping for 8 hours, we only spend 8 hours in bed. Stimulus control as well, using the bed only for sleep or relaxing activities. There are some pharmacological options out there, such as the dual orexin receptor antagonists, known as the DORAs, Z drugs, or specific low-dose antidepressants. Please note that we don't generally encourage long-term use of benzodiazepine medications. And also really important to address other underlying conditions such as sleep apnea, chronic pain, depression, or anxiety that could be contributing also to insomnia. The next slide. Finally, just to wrap up this webinar here before we go into the Q&A, is that there are some pharmacological management strategies for post-stroke fatigue. These are of variable efficacy, mostly off-label use. Okay, the one that does have an indication is modafinil. There was the MIDAS trial published about 10 years ago, I guess 9 years ago, in stroke. And this was modafinil 200 milligrams daily. In my own practice, I've used higher than doses than that to get an effect with post-stroke fatigue. And sometimes it works, sometimes it doesn't work, but at least it's worth trying. There's also methylphenidates. This would be used off-label in stroke. It works for fatigue and other neurological conditions. Solriamfetol is a selective dopamine and norepinephrine reuptake inhibitor. That's one being used in narcolepsy and also sleepiness due to sleep apnea. It's not been studied in stroke. However, it potentially could help as well. Here again, there's variable efficacy for any agent you try in this space. Next slide. Finally, if someone has post-stroke depression concomitant with fatigue, I think it's very reasonable to start an antidepressant medication, but with the understanding that you're not treating the fatigue, that you're treating the depression here. So that's it for my talk. I just want to conclude here that post-stroke fatigue is very common, disabling, yet often unexpected, as we discussed earlier. It remains poorly understood, but effective management strategies do exist. So I think we can go into the Q&A session. I'll just hand it over now to Rebecca. Thank you so much.
Yes, thank you so much. And I'll invite all the presenters to turn their cameras back on and just extend a giant thank you to all of you for sharing your insights and your experiences. And of course, a special thank you to Heather for sharing your lived experience with us. We're really grateful. And we'll now move into the Q&A portion of the webinar. We've received many questions, many excellent questions. So we'll do our best to address as many as we can as time allows. Heather, if it's okay, if we start with you with a question that we received, and it's thinking about your recovery journey. What advice or guidance from healthcare providers or from friends or family was particularly helpful in managing post-stroke fatigue, or was there anything that was not so helpful?
I have to be honest that I had an incredible support from my doctors, my therapists, my family, and my friends. So I had a lot of help. What I really found a little bit challenging at first was their understanding of how to deal with someone who's a stroke victim or stroke survivor. The challenge is that you have initially, I think it's probably because of what I went through, where I went from literally being in a wheelchair to walking and getting around and driving on my own. So people sometimes have a little bit of a problem addressing that you've made the changes. So people are great and very supportive on that part of it, but sometimes they are a little surprised that you can start doing things. So that's one of the things. I think I've been really fortunate with people understanding and actually really, if anything, I would say my physiotherapist and my family have been really uh, uh, adamant that I take the time I need and that I don't overdo. And having that ability to have people talk to you about that was a really big thing. And I've had really good doctors who helped me with different things of this isn't trying, we'll try something else. And that
Mm,
was a real positive. They treated me very much like a human being and not a stroke victim like I've heard from other people. They were very helpful for me, and I can't thank them enough. There are things I had never heard of, and they're always willing to bring something new to me, and we try it. So I'm a big fan of that too.
that's wonderful. Thank you so much. We'll go next to perhaps for Aisha. And you touched on this a little bit in your presentation, but how can rehabilitation providers further adapt their sessions with clients for someone who is experiencing fatigue and respecting the fatigue?
Yeah, so I did touch a bit on that too, right? So the first thing, well, first of all, is kind of remembering whichever role you play to screen and keep an eye out for detecting post-trip fatigue, because maybe your client is experiencing it. That's number one. Number two is kind of adapt your session. So make sure that you're giving enough rest or enough breaks. Also, the exercises that you use might be different for different, for people, or even different day by day for the same person. So be aware of that. If you can alternate for those OTs or anybody who's doing cognitive and physical, try to alternate the two as well and not to overburden. And another thing is, I think planning the timing of our sessions too is important. And I touched on that too. So try to find the time for that specific person that is best for them. And that could make a huge difference. I hope that answered it.
Thank you so much. And Mark, this ties in nicely to what Aisha just spoke to, but is post-stroke fatigue more physical, more cognitive, or is it truly both?
Yeah, I think it can be either, right? It can be really both. And everyone, I think the points that Aisha and Heather really nicely mentioned are everyone experiences it differently. Like my experience would be different than yours, would be different than Heather's, and so on. And but I think it really can be both. Just to answer that though, yeah, or even different. People
Mm,
can experience things that aren't cognitive or physical.
wonderful, thank you. Heather, another question for you, if that's okay. And it's what has helped you stay engaged in recovery and through your journey despite or even and with the fatigue?
I think I just wanted to be able to go back and do as much as I could. I was very, very fortunate because I had my cognitive capabilities came back and very quickly. So that was a huge thing. And I haven't had a lot of depression. So I've been very fortunate from that perspective. Um, my problem probably is going at it too hard sometimes and kicking in. For sure, there's normal fatigue. You do things too much, but really getting to the stage where you're really playing yourself out, and you're just so tired. Your legs just, they honestly feel like you're walking around with weights on them, and it's those sorts of things. So it's really about taking the time and that you need to move accordingly and keep it practical. And by doing that, then you can feel comfortable about trying the next new thing, because
Mm,
I found I always want to try new things, but I have to be a little bit practical about, okay, what is this really going to take me to do?
mhm.
And because it may sound, oh gee, I used to do this. Like for instance, I started driving again, so I thought, oh, no problem. So I went to the store and I got food. And then I realized I have to get these food out of this out of this car and upstairs and to my apartment. And that suddenly became something I hadn't thought of before. And it was a huge undertaking for me. So a lot of the things are thinking your way through it. You can still do it. You just have to think your way through it a little bit more. That's what helps me a lot.
That's great. Thank you. And this question I think could be for any of you really. But we've received a couple of comments, so I'm going to try to group them around the connection that fatigue can have on social isolation or not feeling able to participate socially, and the impact that that can have on mental health. And you've provided some really great strategies around supporting fatigue. But is there anything else that you can think of that really would help support that social participation for somebody?
I would suggest that the social part of it is like anything else I mentioned, you have to learn to do things over again. And I was a very social person and out and about. And now I find I'm more reserved, and it helps me if I still want to do it and get out there, but it's very easy to hide under the covers in bed, and life is wonderful. But what I found has worked well for me is by just making a small thing. And so instead of planning something large and um, formal, starting really small and, very, very casually at first, that's helped me a lot anyway.
Amazing. Thank you. Aisha, did you want to add anything to that?
Well, yeah, I mean, not as someone who's had the lived experience, but someone who's looked kind of in the literature. I think that communicating, so in addition to what Heather had said, I think communicating with the loved ones around you and the people who are part of a social network is important, because they might not fully understand what you're going through. So I think having that communication can help a little bit with, like, no, it's not that I don't want to see you today. It's just like I can't. Or, adapting ways that you could do two tasks at once. Let me go,
Mhm.
go for my walk, and also maybe I can meet my friend at the same time. So those are some suggestions from a non-user point of view.
Wonderful. Thank you. And we probably have time for one really quick last one. And Mark, I'll direct it to you. Um, is there any benefit to tracking fatigue patterns? Is that helpful to bring to your healthcare providers?
Yeah, I think it is. I think it's helpful to know what your triggers are for any given individual. So everyone has different. So some people develop fatigue if they sleep less than 7 hours. Some people develop if they get a cold, or if the weather changes, or they're getting a migraine, or their mood goes down. Really important to track fatigue in that regard and know what the triggers are, so you can direct therapy in that direction.
Amazing. Thank you so much to all of you. And that'll conclude our Q&A portion for today. And thank you to everyone who's been listening for the really thoughtful questions. We so appreciate your engagement in that way. So just a reminder that the recording of this webinar will be uploaded and available on the Heart and Stroke YouTube channel. You can also access it through the Stroke Best Practices website. And we'll add some of those links to the chat here. And lastly, we have a number of resources and supports related to heart and brain health on our websites. And we've included some of those resources that might be of interest to you. And we just want to extend a giant thank you to everybody who's listening to today's webinar. We hope you have a wonderful rest of your week. And thank you.